For how long now? Decades, right? We've leaned on this one single number, HbA1c, to understand, diagnose, and treat type 2 diabetes. We call it the gold standard. But what if it's not so golden? What if it's actually holding us back? Well, today we're going to dig into a really groundbreaking study that suggests a totally new way of doing things, an approach that could completely revolutionize clinical trials as we know them.
All right, here's our game plan. First, we'll tackle the problem with averages. Then, we'll look at a new kind of trial. After that, we'll dive into the amazing story the data told us, show why this new way is better, and wrap up with the big takeaway for anyone in R&D.
All right, let's get right to it. Section 1, the problem with averages, and why that gold standard might not be so golden after all.
So let's just put it out there. I mean, is one single number really enough to get the full picture of a disease as complex as type 2 diabetes? You know, we're talking about something that's tied to everything. Your diet, how you move, your sleep, your genetics, even what's going on in your gut. So how could one little blood test taken once every few months possibly capture all of that? So on the one hand, you've got these episodic tests like HbA1c. Think of it like this. It's like someone shows you a single blurry photo from a 3-hour epic movie and asks you to describe the entire plot. It's just a snapshot, right? It totally misses all the action, the drama, the day-to-day fluctuations. But on the other hand, you have this new idea, continuous multimodal data. Now that is like watching the entire movie in high def. You get these real-time streams of information that show you the dynamic, living reality of the disease.
Okay, so if the old way is just a single photo, how do we actually get to watch the whole movie? That brings us to Section 2, where we'll look at the blueprint from the PROGRESS study. Basically, how they built a whole new kind of camera.
The answer is something called a siteless or decentralized trial. And let me tell you, this is a total game changer. Just think about it. Instead of making people travel to a clinic for every little thing, everything from signing up to giving samples is done right from their own home. It's all handled with digital tech. This completely flips the script, moving from a model that's all about the clinic to one that's all about the participant. It's a huge shift.
And the PROGRESS study really ran with this. They built this amazing multimodal approach. So you've got continuous glucose monitors, you've got wearable trackers for activity and sleep, people are keeping digital food diaries, and on top of all that, they're collecting biosamples like blood, saliva, and stool right at home. You layer all of that on top of their existing electronic health records, and what you get is this incredibly deep, rich, real-world data set. It's the whole picture.
And we're not talking about some small-scale pilot study here. They enrolled over 1,100 people, 1,137 to be exact, all digitally from all across the U.S. This proves that this decentralized model isn't just some nice idea on paper. It's a real, scalable way to get people into trials. But here's maybe the most incredible result of going siteless, the diversity. Look at this. Nearly half the participants, 48.1%, were from groups that are typically underrepresented in research. I mean, that's huge. When you get rid of the need for people to travel to a specific clinic, you suddenly open the doors to a much broader, more representative group of people. And for anyone running a trial, you know how crucial that is. It means your data is just better. It's more reflective of the real world.
Okay, so they've built this better mousetrap, they've gathered all this fantastic, rich data. So what did they find? What's the big story here? Let's jump into Section 3 and see what the data revealed.
The big flashing headline from all this? Averages are misleading. In fact, they can flat out lie. These continuous streams of data showed huge, hidden differences in how each person's body handles glucose. And these are differences that an HbA1c test would miss completely. It's like they were invisible before.
Take a look at this. This chart shows something called spike resolution time. It's basically how quickly your body can get your glucose levels back to normal after they spike. And the difference is just crystal clear. You can see that folks with type 2 diabetes take way longer to recover from a spike compared to people who are pre-diabetic or have normal glucose levels. This is a dynamic, vital sign, something you could never, ever see with a simple blood draw.
And it didn't stop there. The really cool part is the surprising connections they found. Things like a more diverse gut microbiome was linked to healthier glucose. More physical activity, obviously, meant better glucose control. But then you see things like a higher resting heart rate being tied to that slower spike recovery time. And this is where it gets really exciting for R&D, because each one of these correlations, the gut, sleep, heart rate, is a potential new target for a therapy. We're moving way beyond just thinking about blood sugar.
All right, this all leads up to the real climax of the story. Because the researchers didn't just collect all these fascinating new data points. They used them to build something incredible, a model for predicting risk that blows the old standard out of the water.
You know, the authors of the study really said it perfectly. They wrote that they saw substantial variability in the risk profile for the same values of HbA1c. Let's break that down. What they're saying is, even when two people have the exact same HbA1c score, their actual risk could be wildly different. Their model provides a whole new dimension of information that we were completely blind to before. And this right here is where you really see the power. Take a look at this. Imagine 3 different people. They all go to the lab, get their blood drawn, and they all come back with the exact same HbA1c, 5.8%. Under the old system, they all get the same label, pre-diabetic. They're all in the same bucket. But the new AI model looks at their entire data profile, their sleep, their activity, their glucose spikes, and it sees 3 completely different stories. It can say, okay, participant A is actually low risk. Participant B is medium, but participant C, they're high risk. Now, if you're designing a trial for a new preventative drug, which of those 3 people do you want to enroll? The old test can't help you. This new model tells you exactly who you need to talk to.
So just how good is this model? Well, for the data nerds out there, it achieved an AUC, that's area under the curve, a measure of accuracy, of 0.96. To put that in plain English, that's almost perfect. A score of 1.0 is a perfect prediction. So 0.96 is, well, it's incredibly accurate. It just shows how powerful this approach is.
Okay, so let's bring it all home. What does this actually mean for you if you're in pharma R&D? This is our final section, and it's all about the new playbook this creates for developing drugs.
Look, the takeaways for your R&D pipeline are just massive. First, you get way better data, real-world, continuous data, not just those lab snapshots. Second, you get a much richer understanding of your patients. You can see the nuances beyond a simple diagnosis. Third, because it's decentralized, you can recruit a more diverse group of people, and you can do it faster. Fourth, you start to uncover brand new targets for therapies, like the microbiome or sleep patterns. And maybe most importantly, fifth, you can actually identify the truly high-risk people for your preventive trials. Think about what that does for your trial's efficiency and your odds of success. It's a game changer.
So I'll just leave you with this final question to think about. All the evidence is pointing in this direction, towards more detailed, more dynamic, more digital trials. So really, the question isn't if things are going to change, it's when. The real question you have to ask yourself is this: is your clinical trial strategy still built for the past, or is it ready for the multimodal future that's already here?